U.S. and Global Healthcare. Part 1, U.S. Healthcare Economics. Let's challenge your thinking a little bit. The economic influence has a major impact on healthcare services. These are things that I know U.S. practicing RNs are already aware of, but let's make sure that we have a defined and a consistent understanding of these concepts, starting with just defining economics. This is the way in which society distributes its resources to address the human wants and needs. Currently, the federal government and the states are experiencing an economic crisis that affects the health of the population as well as the healthcare services that are provided. And the results of this crisis is for several reasons. One, the recent tax cuts, poor economic performance, increased expenditures both on the defense and national security, which leads to greater scarcity of health resources and more severe effects on the health of the population, with two major aspects of the interrelationship between economics and health and the financing of the healthcare system. So what is this relationship between economics and health? There are three fundamental principles. Resources are more limited than what is needed. Resources have alternative use. Different people will have differing ideas of how resources should be used. Economic factors influence availability of and access to healthcare services, affecting the health status of individuals and/or families and the overall population. Societal productivity and stability are affected by the nation's overall health status. Populations are affected by chronic illness, poverty, and general ill health costs society in lost productivity and decreased revenues. The amount of money spent on U.S. healthcare services increases at an alarming rate for the last several years. The per capita expenditures goes up. Per capita is the average amount spent on healthcare per person per year. The factors that contribute to increased healthcare costs are that of the aging population. Older adults require more health care for chronic diseases, which costs more. Greater use of technology. This is a partial fear of malpractice and the greater use of specialty care. Emphasis on costly specialty care and costs for care for the uninsured. The proportion of care with which the provider receives no reimbursement and includes both charity care and reimbursement. And then the U.S. drug prices. U.S. drug prices have risen considerably more than the Consumer Price Index. Uncompensated care leads to cost shifting. You'll want to know this concept. Cost of an uncompensated care to those who do not pay, either those who pay out of pocket to cover the health care to be covered by healthcare insurance. Consumer Price Index is defined as a measure of the average change over time in prices paid by urban consumers for a market base of consumer goods and services. Poverty leads to malnutrition, poor housing, lack of health care, lack of adequate child care, and associated with low literacy levels, which limit the earning power and access to health care. Health disparities, which is defined by Healthy People 2020, is a particular type of health difference that is closely linked with social and economic disadvantage. The lack of health insurance is the most common among the young to middle-aged adults. The reasons are being that of job loss, their age, no more employment-based benefits, the job doesn't provide benefits, eligibility, or a death of an insured spouse or lost in a divorce. Health insurance. Uninsured are less likely to receive cancer screenings or comply with medication regimens, and less likely to have access to health care. Healthcare has access to better health status, regular source of care, and more appropriate use of healthcare services. Lack of healthcare access has that of unmet health needs, delay in receiving care, inability to prevent preventative services, and an increase in hospitalizations that could have been prevented. Payment for health services or reimbursement involves two aspects: the way in which payments are made and the source for the funds of payment. Retrospective reimbursement is the form of payment that is made for services based upon and the cost is determined after the fact. The discounted fee for service payment and a fee for service payment are examples of retrospective reimbursement. Prospective reimbursement is the payment that is made at a predetermined fixed rate for a specific healthcare program or set of services. Forms of prospective payment include diagnosis-related groups, or DRGs, and resource-based relative value scale, RBRVS. Capitation is the type of prospective reimbursement. This is when the provider or the healthcare system is paid at a set predetermined fee for a defined set of health services for each client enrolled in a particular health plan. This is a prominent feature of many managed healthcare plans. Pay for performance, which is something new that many hospitals are going to, and that Brian even started this spring. Providers and healthcare institutions receive bonus pay for achieving specific quality outcomes. A reverse approach to pay for performance are the never events, or SREs. Serious reportable events, or SREs, are serious errors and events that include errors caused by care management rather than the underlying disease, and errors that occur from failure to follow standard care. The current list includes 28 events in 6 categories such as surgical, product or devices, patient protection, care management, environmental, and criminal. SREs, or hospital-acquired conditions, are basically preventable with the quality of care and should never occur. Based upon the concepts of SREs, Medicare developed a list of HIC incorporating multiple diagnosis codes for which healthcare institutions will not be reimbursed for care, although care to address adverse patient effects must be provided. The second aspect of payment for healthcare services involves the source of funds for payment. Personal payment is the first one. This is usually done by very wealthy, uninsured, or specific goods and services that are not covered by insurance plans. This comprises one part of out-of-pocket expenses incurred by people who receive healthcare services. Other components of out-of-pocket spending are insurance premiums, deductibles, and co-payments. They are either traditional fee-for-service retrospective reimbursement or a managed care approach to healthcare. The managed care plans usually have 2 elements in common. Generally require some form of authorization for services, particularly specialty services, and usually include some restriction on choice of providers. Here you can see what it was like in 2012, only 4 years ago, where personal health care expenditures were done in the amount of $2.3 trillion. Notice that is pretty even with Medicaid and Medicare, slightly higher with Medicare, and private insurance being at 34%, where most of the expenditures were done in either hospital or physician and clinical services. So it tells us where we need to manage our time better here is in the physician and clinical services. Individual insurances is usually purchased by an individual directly from an insurance company. It usually has limited coverage and the person is not eligible for other coverage due to pre-existing health cares. Employment-based health plans employers are faced with one of several unpleasant options due to rising premium costs. They pay the increased premiums, thereby reducing their profit margins, and reduce the level of benefits covered, pass a large shard of the health insurance costs onto the employees, and discontinue coverage altogether. Increases in the cost of health insurance have led to multiplying the types of employment-based coverage in an effort to reduce costs to employers, including defined benefit plans, defined contribution plans, fixed contribution plans, consumer-driven plans. They don't go far to cover the cost of a desirable health insurance plan. Self-funded insurance has the advantage of avoiding third party that increases premium costs. The costs are based on the level of pooled risk. This avoids the premium tax. They're exempt from state insurance regulations. Minimum benefit requirements of commercial plans are not required and provide a tailored health benefit package. Self-insured programs is similar, but employing organizations hire a third party, often a commercial insurance company, to administer the program and process the claims.